Should we get started now? I think people are
Yes.
coming back. Yeah, okay. So like I said, this lecture is going to be a little bit shorter because there is some overlap with type 1, and then we'll finish with some questions, prep questions at the end. Okay. Okay. So type 2 diabetes, they basically want you to, of course, understand the difference between type 1 and type 2, do know some of the treatments, some of the signs of it, screening tests and complications of type 2 as well. And again, there you'll see that a lot of them are the same as the things that we just talked about. So the pathogenesis of type 2 is, of course, different from type 1, right? So type 2 diabetes, whereas type 1 was an insulin deficiency, type 2 diabetes is more insulin resistance. And then as you have progressive insulin resistance, you have a relative insulin deficiency because you're not able to keep up. So essentially the insulin resistance develops, and sometimes we're still figuring out exactly why. There's a genetic component, there can be a lifestyle component because of the carbohydrate intake, but for whatever reason, your body is not responding to the insulin properly. And so after a while, the amount of insulin that your body is producing, it produces more and more and more insulin to keep your blood sugars in the normal range. And after a while, it's not able to do that anymore. It's not able to keep up. And so at that point, your blood sugar starts to go up because of this relative insulin deficiency. And then at that point, you can have symptoms of type 2 diabetes. In addition to that, so this picture is from the Peds in Review article on type 2, and the purpose of the diagram was to talk about the different treatments, but it also has a little bit of the pathogenesis to it, which is why I included in here. So you have the insulin resistance, then you have impaired insulin secretion as the pancreas tires out, and then, you know, because you're resistant to the insulin, you can have increased glucose output, which you know, worsens the hyperglycemia, and then obesity. So increased adipose tissue can also lead to increased free fatty acids, inflammatory markers, which also inhibit insulin production, making the whole problem worse. So this is what also all leads to worsening hyperglycemia. Okay, so the clinical presentation, same as type 1, polyuria, polydipsia, polyphagia, weight loss. These patients are often obese and overweight, but not always. So you can have type 2 diabetes and someone who appears to be an average weight. It's, you know, so don't let that throw you off. And acanthosis as well is a sign of insulin resistance. And the reasoning behind that is thought to be because insulin leads to increased it can increase the fibrosis of the skin. So basically the things that make the skin thicker, insulin can increase those factors. And so that's why you have acanthosis. And the presentation or the development of type 2 diabetes is often insidious. So for type 1, while we don't know how much time elapses between the antibody presence and the development of the symptoms, it usually does tend to be sort of weeks or months. So it's a shorter period of time. For type 2, it generally develops over years. And so you notice that these kids' blood sugars or A1Cs most often are gradually increasing, like, you know, 5.7, 5.9, 6. So it takes years for this to develop, and especially if they're not seeking medical attention as regularly. You know, they may already have, you know, some of the complications without really being symptomatic at presentation. So you can have someone whose A1C is 6.8 or 6.9, but because their blood sugars have been slowly increasing, it doesn't impact them as much, so they don't feel any different. So this is just, I mean, sure, you've seen acanthosis, but this is just what it looks like. It's, you know, with people who have darker skin at baseline, it can present as a skin darkening. In addition to the thickening, it's usually around the neck and the axillae, basically in the skin creases is where you see it most often. In people who have lighter skin, it's sometimes harder to see. You don't necessarily get the darkening as much, it's just thicker skin. So it can be sometimes a little bit difficult to see in people who have lighter skin. So in terms of who should be screened for type 2 diabetes, so the recommendation for the American Diabetes Association is that if you have children and adolescents who have either started puberty or are older than 10, whichever comes earlier, who are overweight or obese, so if they have a BMI greater than the 85th percentile or greater than the 95th, and who have one or more additional risk factors for diabetes, which we'll talk about on the next slide. So this is the general population that it's recommended to screen for type 2 diabetes. And I'll talk about what the screening tests are, but if they're normal, the recommendation is to repeat the testing at least every 3 years. But if their weight or BMI continues to increase, then it's recommended to do it more frequently than that. So the additional risk factors are obesity, non-European ethnicity, so the highest incidence of type 2 tends to be in Native American children and African American children. Maternal history of gestational diabetes is also a risk factor. And the SGA and LGA kind of tie into that. So a lot of children who have maternal history of gestational diabetes tend to be LGA. SGA as well is a risk factor because it's tied to insulin resistance. And so twin gestation kind of similarly is tied to being SGA. So those kind of go together. Female children tend to develop type 2 at a greater rate than male children, and it's thought to be because for whatever reason they have an increased rate of insulin resistance, just because of the general body shape differences. You can have more subcutaneous fat development as well, so that's
Dr.
why.
Swami, 3298, Dr. Swami,
Low socioeconomic status, because this can lead to, depending on where they live, they may not have access to healthy food options or ways to exercise or the usual things that we tell people to keep healthy. And then family history, of course, is also a risk factor. And this is specifically type 2. So with type 1, I mentioned, the family history is important, but more often you have someone develop type 1 who has no family history at all. Or if they do have some family history, they may have other autoimmune conditions in the family, like Hashimoto's or celiac disease or something like that. With type 2 diabetes specifically, you will most likely see, a parent or grandparent, if not more people in the family with type 2. Especially if they develop it at a young age. Okay, so this is the genetics of it. So the first degree relatives of people with type 2 have a 30 to 40% absolute risk of developing the condition versus 7% in the general population. So you can see that compared to type 1, where it was like it was an increased risk, but not by that much. This is 30 to 40% compared to 7% in the general population. They have found certain gene polymorphisms that are associated with developing type 2. One of them is this gene. You don't need to know this specifically, but just as an example of a gene that's known to be associated with impaired insulin secretion and defective insulin processing. But they are still, they don't quite have a great understanding of which genes are associated with this. Okay. So which screening test do we use to screen for type 2?
Seem like fasting glucose, random A1C.
Yeah, exactly. So fasting glucose,
symptoms
A1C,
associated with it.
Right. So A1C and the fasting glucose are probably the easiest to measure, especially since the A1C does not have to be done fasting. And the oral glucose tolerance test, if you have the capability of doing that, it is sort of the gold standard, but it's a little hard to do because it's a 2-hour test. So that's why it's not done as commonly. Right. So the criteria are the same, as I said, for type 1 and type 2. So fasting, blood sugar greater than 126, 2-hour, OGTT greater than 200, random glucose greater than 200, A1C greater than 6.5, with the signs and symptoms. Okay. And as I said, if they're asymptomatic, if you have a random value that tends to fit this criteria, it's always good to get a repeat level, either the same test or a different test on a different day to make sure that the diagnosis is correct. Okay, so what else needs to be tested at the time of diagnosis? So these are some of the things that we look for, right? So the blood pressure. Yeah, exactly. So some of the comorbidities like fasting lipids, you want to check the urine microalbumin to creatinine ratio. Eye exam, and then always, if someone fits the criteria of diabetes, you want to rule out type 1, because even in patients who are obese, have acanthosis, they can still develop type 1 diabetes, and because the treatment is so different, you want to make sure that you're not missing something. And then you want to screen for symptoms of complications that are associated with obesity, like PCOS, sleep apnea, fatty liver disease, orthopedic issues like like hip displacement. And then psychosocial concerns like anxiety, depression. And the reason for doing all of this at the time of diagnosis is that because type 2 tends to present so insidiously, as I said, if they don't have access to regular medical care or they missed some doctor's visits and it wasn't caught in time to do something about it earlier, they may have already developed some of these complications of diabetes. You know, it may be that this has been going on for a lot longer than they realized, especially if they're asymptomatic. So you want to make sure that they haven't already, you know, progressed to having some of these complications. Again, this is less common in children than in adults to have some of these issues going on, but you know, you certainly can have them, so you want to make sure to get them into that habit.
Dr. Kharode, I have a question.
Yep.
How much it will be difference between measuring a fasting lipids versus non-fasting? Like, how much difference will you have you seen? Because most of the time with all these obese adolescents and even like children in our clinic, we do all the tests, hemoglobin A1C, when they're increasing the weight, and we suspect that maybe they're going to a diabetes case, and then they do the lipid without fasting. So I'm just wondering how much have you seen? Yes.
Yeah, so no, that's a good question. So the general thought is that if you are measuring someone's lipids for the first time, or if someone doesn't have any history of abnormalities, a non-fasting profile is okay. The main thing that changes in fasting versus non-fasting is the triglycerides. So a lot of times I'll get referrals for people who have triglycerides of like 200, 300, but then I check and it's done at like 3 o'clock in the afternoon, so most likely non-fasting. And these kids, so before assuming that this child has hypertriglyceridemia, it's always good to get a fasting sample to make sure, because sometimes it may just be that they ate something and that affected, because triglycerides are connected to carbohydrates and like blood sugars. So that's the main difference. Sometimes total cholesterol can be a little bit affected by fasting versus non-fasting, but it's the triglycerides that are mostly affected. So the fasting is obviously most accurate. If you're not able to do that, if you're drawing blood anyway, you can do a non-fasting. It's just important to keep that in mind, that you know, you may see values that are false.
Okay, thank you.
Also, Dr. Kharode, regarding the insulin, we do like insulin, right? It's usually fasting insulin we do for insulin resistance.
That's another one. So insulin, I would not do non-fasting insulin because it doesn't tell you anything. Because you know it's going to be high no matter what. So that's another thing I've gotten to is patients who come in and they're like, well, they told me my insulin was high, and I said, yeah, but you know, like I had family last week who they had like a giant chocolate bar before they had labs done. And so of course their insulin was like 70 because that's that's what happens. So yeah, if you're gonna do non-fasting, I would CMP is fine, A1C, lipid profile is fine as long as you are aware that the triglycerides might be high. Thyroid tests if you haven't done them, and a vitamin D. So most of the tests that you would do in an obese trial, the only thing I wouldn't do is the insulin because it just is kind of, it doesn't tell you anything.
And also, is it the insulin-free insulin or the total insulin we do?
Well, I don't know what free insulin is. I mean, I know what it technically is, but I don't, like it's not I don't know under what circumstances it would be useful, to be honest with you. So yeah, total.
Okay. Okay.
Yeah. Okay. All right, so sort of like we talked about DKA in the other lecture, I'm just gonna do a quick thing on hyperglycemic hyperosmolar syndrome, which is far less common, but it's very dangerous. So I do wanna make sure we mention it. So this is caused, it's a little bit similar to development, to DKA. So you have this relative insulin deficiency for whatever reason, either because they were on insulin and didn't take it, or because they have a very severe presentation of type 2. In addition to the physiological stress of illness or whatever that, you know, causes these counter-regulatory hormones to increase. So again, you have increased mobilization of glucose leading to hyperglycemia. But in this case, the main difference is, you know, you do get, you know, the dehydration, the polyuria, glycosuria, and impaired renal function that goes along with that. But you can also have increased intravascular osmolarity because the development of hyperglycemic hyperosmolar syndrome is very, because it's with type 2, it can occur very slowly. And so the blood sugar can get very, very high before you start to see any of these symptoms, especially because in type 2, you typically don't have ketone production. You can in certain rare cases, but typically you don't have ketones. So you don't get those symptoms of nausea and vomiting that you would right away in the development of DKA. So your blood sugar can get very, very high, which can cause increased osmolarity intravascularly. So the hyperosmolarity leads to additional extravascular dehydration. So these patients can become very, very dehydrated. And because sometimes it's mistaken for DKA and treated like it's DKA, this can actually worsen the problem. So it's important to kind of know what you're looking at. Okay, so the difference between DKA and HHS, so this is the sort of breakdown between the two, right? So in general, for DKA and HHS, the blood sugar tends to be high, but in HHS, the blood sugar tends to be really, really high, so above 600. The pH tends to be normal, again, because you don't have that ketone production, you don't have acidosis, so you have a normal bicarb as well. The ketones, you can have small ketones from dehydration, but it's generally not as much as in DKA. Like in DKA, you usually see like moderate or large ketones on the UA. Osmolarity, again, very high, greater than 320. And the difference in management is that you don't start with the insulin until you've corrected the hydration. That's the main thing. Because if you give insulin, at this point, the high blood sugar is really what's maintaining the sort of kind of retaining fluid intravascularly. And so if you give insulin and drop the blood sugar too quickly, you can actually cause intravascular collapse and make the problem even worse. And so the idea is to correct their dehydration before starting insulin. Okay, so usually you kind of just give them bolus after bolus, have them on like twice maintenance, just with fluids, and then until their blood sugar drops more slowly, that's when you start insulin. So typically, I think the cutoff they use is like less than 100 per hour. Once the blood sugar stabilizes somewhat, that's when you start insulin. That's when it's safe to do that. Okay. The potential complications are also a little bit different because they're so dehydrated. They can become more likely to have blood clotting. So thromboembolism is a concern. Rhabdomyolysis as well. I think just because of like organ injury. And then there's also a malignant hyperthermia lake syndrome that's not completely understood, but you can see that with HHS as well. And I have actually seen a patient who had HHS when she was presenting with type 2, and then she was discharged and then came back a week later with a PE. So it's definitely, it's rare, but it does happen, so it's important to watch out for it. Okay. Okay. So that, yeah, I mean, DKA tends to be more tested than HHS does, but I just, like I said, I just wanted to mention it because clinically it's important to distinguish between the two. All right, so managing type 2. So this is a little different from type 1 because the first thing we start off with is lifestyle management. So in general, the recommendation from the ADA is to reduce your overall carbohydrate intake. So already we see that it's different from type 2, right? Because type 1, you don't have many dietary restrictions because it's not as tied to your diet. With type 2, you want to decrease your carb intake. And if you're eating carbs, of course, which you need to do somewhat, carbs that are high in fiber, non-starchy vegetables, fruits, whole grains. So getting your carbohydrates from more healthy sources rather than, like cake and chips and things like that. Now, it's also tricky if you have children who are still growing when they're diagnosed with type 2. Typically, it happens in post-pubertal children, but if you have children that are still growing, you don't want to tell them to completely eliminate carbs because that can compromise their growth. So it's a tricky balance, but it's just important to emphasize like the source of their nutrition. No sugary beverages, they really should just be drinking water. And this is kind of the case with most children, but especially with type 2. And in terms of fats, unsaturated fats in general are preferred. And then physical activity, they should have at least 30 to 60 minutes of physical activity at least 5 days out of the week. The recommendation from the ADA is to do some sort of strength training at least 3 days a week. It's hard to kind of get someone who has been sedentary to all of a sudden start doing this. So the main thing is some physical activity is better than none, but this is the goal. And they should decrease their sedentary behavior as much as possible. So decreasing screen time, if that's possible, as long as it's not tied to their schoolwork. Getting up and walking around at least a few days a week, if not more than that. Okay. So the glycemic target here is a little lower than for type 1 because with type 2, if you're not on insulin, you're less likely to become hypoglycemic. So you can have a lower target and still be safe. So the target here is less than 7 rather than 7.5 for type 1. And as far as blood sugar monitoring, it depends. If you're only on metformin, you typically don't have to monitor your blood sugars as much because the metformin itself is, and we'll talk about metformin, but it doesn't really cause hypoglycemia. So the main reason to check your blood sugars is really just to make sure that your diabetes isn't worsening to the point where you need additional medications. So with these patients, everybody has a different thing that they do. For me, like a couple of times a week is fine, as long as their blood sugars are stable. If you're on insulin or if you're on the other medication that I'll mention, you do have to monitor a little bit more than that because you're taking a medication that actively lowers your blood sugar. So you want to make sure that you're in a safe range. Okay. So pharmacological treatment has to be started at the time of diagnosis. In metabolically stable patients, so this is defined as someone who has an A1C less than 8.5 and is asymptomatic, metformin is the initial treatment. Okay. Insulin is recommended when you have very high blood sugars, above 250, or if your A1C is greater than 8.5, or if you've tried metformin and they didn't tolerate it because of side effects, or if there's some sort of contraindication to it. And in patients who are on both metformin and insulin, the goal is that if you have started insulin, hopefully you can come off of it or at least lower the dosing of it once you start the metformin, that kicks in. So this is, again, from the American Diabetes Association. So in general, of course, they say to measure antibodies in everybody, but as long as you have negative antibodies, and if you have a low A1C, you can continue just the metformin. In patients who have a high A1C, again, starting insulin and metformin at the same time. And the idea is to, as you go up on the metformin dose, hopefully you can come down on the insulin and maybe take it off completely. Obviously, if they present with hyperglycemic hyperosmolar syndrome, you have to start insulin right away and kind of manage that before you then get into the daily management of it. Okay, and then if you're on metformin but they're not meeting their A1C goals, then you may need to, even if you didn't start insulin to begin with, they may then need it if they're not maintaining their blood sugars properly. Okay, so metformin is a medication that reduces hepatic glucose production and it improves insulin sensitivity. So it makes your body more sensitive to the insulin that you're producing. And it increases the insulin-mediated glucose uptake in muscle and adipose cells. So the idea is that if you take the metformin, it decreases the insulin resistance to the point where hopefully your pancreas doesn't have to work as hard to make all that insulin. It can produce less insulin and have the same effect on the blood sugars. So hopefully your pancreas doesn't tire out to the point where you become hyperglycemic. So the starting dose is 500 milligrams a day. Honestly, this dose, I don't know how much it really does. So the minimal dose that I try to have people on is 1,000 daily. And then the maximum dose is 2,000 milligrams daily. The potential adverse effects are most commonly GI side effects, so abdominal pain, nausea, vomiting, diarrhea. Sometimes some people develop them at the beginning, but then they resolve after a couple of weeks. I always tell patients to take the medication with food because that tends to minimize the GI upset. And also, you usually start at a lower dose and then titrate up. So the reason for starting at 500 and then increasing is so that you make sure that they tolerate the dosing rather than starting them on like 1,000 or 2,000 right away. Theoretically, there is a risk of lactic acidosis. This is very rarely actually seen in practice, but there is a risk according to some of the literature. So it's contraindicated in patients with liver disease, renal disease, and heart failure. I would say that with the liver disease, a lot of patients with type 2 diabetes also have fatty liver disease. But in these patients, as long as you talk to their GI specialist, usually they're fine with them taking metformin. because the risk of not controlling the diabetes is more than any effect that it can have on the liver. So you may have elevated LFTs, but you usually don't see a lot of liver damage. So even though technically it says it's contraindicating liver disease, in practice, usually you're able to work out something and have them take it anyway. And as I said, because it doesn't directly affect blood sugars, it sort of indirectly acts through the sensitivity of insulin, it doesn't cause hypoglycemia when it's used by itself. So if you have a patient who's on metformin and complaining that they feel like their blood sugars are low all the time, if that's actually the case, it's not from the metformin, or they're having these symptoms because of something else. Okay. This is another medication. This is a newer one that was just approved last year for children with type 2 diabetes. It was previously just approved in adults. So liraglutide is a glucagon-like peptide 1 analog. And so it stimulates insulin secretion, decreases glucagon secretion, and then it also delays gastric emptying. So it reduces appetite, which can then lead to some weight loss. So this is given as a daily subcutaneous injection. You can see that it's pretty similar to an insulin pen.
Mm-hmm.
So it's given the same way, and it's once a day. There have been studies that use this medication only for weight loss because of the reduced appetite component to it. So it is being studied that way. It's not FDA approved for that yet, but there are some studies coming out to see if this can potentially be used to lose weight. But it does have side effects, so it's something that needs to be kind of monitored really closely. The starting dose is 0.6 milligrams daily, and the maximum dose is 3 milligrams. Potential GI side effects include GI side effects, very similar to metformin. And then hypoglycemia, because it directly affects insulin secretion, that's why this medication can be linked to hypoglycemia. So because of these side effects, you want to make sure that if you're using this in someone who doesn't have diabetes, you're only using it for weight loss, that you really kind of counsel them on the potential adverse effects, and make sure that their blood sugars are staying safe and all of that. As I said, it's not FDA approved for that purpose yet, but
Does it have an oral?
There's no oral component. Yeah, it's just an injection, which is also another reason, like for weight loss, some people may not want to give them injection every single day. Theoretically, it should be easier to do diet and exercise, but if that's not working, or if that's not something that's happening, and they may be reaching a dangerous BMI, then some people have sort of experimentally used this for that purpose. So. Okay. And then insulin we talked about, it's similar dosing to type 1. Depending on how high their blood sugars are or when they're having their high blood sugars during the day, they may not necessarily need both long-acting and short-acting insulin. There are some patients whose fasting blood sugars are fine, but once they start eating something, their blood sugars later in the day tend to go up, their postprandial blood sugars. And so for those patients, they may not need the Lantus, they may just be fine with the short-acting Humalog or Novolog or whatever. Again, people do the dosing a little bit differently. I tend to, for patients who I absolutely know have type 2 diabetes, I sometimes tend to do fixed insulin dosing, which is to say they get the same amount or like a known amount of insulin for their meals rather than doing carb counting and the correction factor. And the rationale for this is because they do have some residual insulin production. So it's not like they don't make anything at all and you're supplementing all of their insulin. So you don't have to be as precise with the dosing in these patients. So, again, that's sort of a personal preference. Some people also do like a sliding scale where like, okay, if your blood sugar before you eat is between 100, 200, give yourself this much. If it's 200, 300, give this much. So there's different ways to do the dosing in type 2 patients, but the basic idea is the same. Okay. And the comorbidities, again, for type 1 and type 2 are also essentially the same. But as I said, the complications start at diagnosis because they may already be present depending on how long this has been going on for. Okay, so that's type 2. We have a few questions that we can do for practice, and these are both pertaining to type 1 and type 2, so feel free to shout out the answer. Okay. All right. So we have a 6-year-old girl admitted for new onset hyperglycemia. She had a fasting blood sugar greater than 250. She's had symptoms for about 2 weeks, looks sick. the most appropriate of the following serum levels to measure first is it autoantibodies, electrolytes, insulin, lipids, or transaminases?
B.
B.
Yeah,
Electrolytes.
B.
Exactly, because you want. What are you worried about with?
Ask the daddy.
Yeah, exactly, you want to make sure she's not
Acidic
acidotic.
or-
Yeah, that she's not in DK, basically. Okay, good. Right. Among the following factors, which is most likely to protect a 13-year-old patient against type 2 diabetes? Is it being an adolescent, female, history of being breastfed, mother who had gestational diabetes, or being Native American?
C.
C.
Exactly, right? Because all of the other ones we talk about as being risk factors,
Risk
right?
factors.
So his history of being breastfed has actually been shown to be somewhat protective. I don't know how much how protective it is versus like if you have anything else, that I don't know, but out of all of these, this is the only one that's not a risk factor. Okay. A 3-year-old boy presents to the emergency department in DKA, blood sugar of 450. You resuscitate him with isotonic solution, admit him to the ICU for monitoring. He is treated with normal saline and insulin at 0.1 units per kilo per hour. His blood sugar gradually falls to 180, but the ketosis persists and the bicarb is 13. At this time, the most appropriate medical management is, do you add
C.
bicarb? Correct.
C. Yeah.
Yes. So the bicarb, I mean, anytime you see this, it's like not the answer. There are very specific times there's like to use bicarb, but like for testing purposes, they never really asked about those as far as I know.
He actually sends 7.
Yeah, like sometimes if they say if it's severe DK,
Yeah.
like, you know, like, yeah, a pH less than 7 or something like that. But in practice, I have never seen anybody use bicarb. And on testing, they tend to like add this as like a joke choice. Obviously, you don't want to discontinue insulin because he still has ketones. And you aren't going to discontinue the IV fluids and change to sub-Q because he's not out of DKA yet. So correct, you add dextro. So that's basically the 2-bag system. 17-year-old boy develops altered mental status and is rapidly brought to the emergency department. 4 days ago, he complained of polyuria, polydipsia, and fatigue. He lost 4.5 kilos over the past week. Vitals show blood pressure of 146/53, pulse 133, and a respiratory rate of 16. He's afebrile and his BMI is 30. Current medications include olanzapine, started a few weeks ago for schizophrenia, sertraline, and valproic acid, which he has taken for a long time. Initial labs show blood glucose 660, sodium 161, potassium 4.8, and bicarb 23. What does he have?
B.
Yeah, exactly, right? Because you see that he has a really high blood sugar above 600. He's hypernatremic, right? Exactly. The antipsychotic medication can certainly increase your blood sugars. So it's not DKA. It doesn't really fit in with this. Medication overdose, no, because none of these are going to cause these sorts of symptoms. And the same thing with the toxic ingestion. This is really more consistent with HHS rather than anything else. Okay. A 16-year-old girl with type 1 diabetes is seen in the clinic for recurrent DKA. She's 5'6" and weighs 100 pounds. She's a well-adjusted honor student. Teachers say she's very pleasant, gets along very well with her peers. Which of the following is most likely to be associated with her recurrent episodes of DKA? So fear of weight gain. Fear of
Weight gain.
Yeah, right. So the kind of clues they're pointing at. She's underweight. You can tell if she I can't calculate her BMI in her head right now, but like, you know, she's 100 pounds and she's 5'6", so she's underweight. I think with the well-adjusted honor roll student, they're kind of trying to point you in the direction of like she's very kind of high achieving, very particular. So there's nothing to suggest any of these other ones. You know, she might be doing these, but you know, it's most the fear of the weight gain that they're pointing you towards. Okay. A 10-year-old girl with no significant medical history is brought to the ER for vomiting, abdominal pain, polyuria, polydipsia, dehydration, and weight loss. DK. In addition to glucose, ketones, and electrolytes, which of the following is not recommended as part of the initial lab workup?
ESR maybe?
Is
Yeah, A.
Right. So the reasoning is you know, the antibodies, you do want to measure at the time of diagnosis, obviously, to tell you what the diagnosis is. The A1C you should measure. Thyroid peroxidase antibodies, as I said, you can measure them at the time of diagnosis to check for comorbidities. The ESR is the only one it doesn't really give you any information about DK. It doesn't really have any place. Okay. 17-year-old girl with poorly controlled type 1. Blood pressure is elevated. A1C is 11.5. Her screening tests are normal. Of the following, the intervention most likely to reduce long-term renal complications in this child is?
C.
T.
So it's actually D. So the way they're pointing is if she achieves glycemic control, then that should protect her kidneys long term. So she may require ACE inhibitor therapy at some point, but the best way to prevent renal complications down the line is to get a better control of her blood sugar. The statin and the statin, she has high cholesterol. Physical activity may help, but that's sort of indirectly related to bringing her blood sugar down. And a low salt diet, again, I mean, it may help with her blood sugar, but this is sort of taking care of the underlying cause. So that's why they're pointing you in that direction. Okay. Any questions?
Thank you, Dr. Kharode.
Okay.
Thank you.
Thank you, Dr. Kaur.
Thank you.
Thank you, Dr. Kharode.